This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, I'm here with another intraoperative complication which was very difficult for me to explain. So she is an 70-year-old lady who has come for an age-related cataract. She has got a mature intermittent lens. So I'm going to fast forward the case here. There's nothing much happening. Phaco is completed. The hands are switched. Cortex aspiration is being done and a few fibers are being aspirated here. It looks all right. The cortex aspiration is completed. And I've already asked my assistant to shift the next case. So before I continue with the video, I just like to pause here and try to answer a very common query or comment which I get from viewers across the world. Why do I use the multi-piece lens so often? Number one reason, in India, most of the patients pay out of their pockets. We don't have any insurance coverage in majority of the cases. At least in my practice, multinational company, a 3-piece lens is relatively less costlier than the single-piece ones, and that's the reason why patients opt for that. This is one of the package which we have, and that's the reason why I use it. And it serves me well. It has got one of the least PCO rates, and the results are quite good. So getting that out of the way now, so lens is being implanted. The chamber was very well filled with OVD. The distal haptic is now being released into the bag very gently. Now the trailing haptic is being guided into the bag. And so far so good. Everything looks alright. There's nothing unusual happening at this stage. Time to remove the OVD. And these are routine steps which I do for every case. Some amount of the cortex is still remaining after IOL implantation. So I'm going to remove this cortex. And to remove the OVD from behind the lens, only the irrigation cannula is gone in, and I'm just trying to irrigate out the OVD. Just bear with me as you can see the incident happen now. So these are routine movements, nothing unusual, nothing fancy. And there is a small wave which is appearing here, but which was not very much clear when I was doing the surgery live. Now on rewind I can see this, and after some time you can see the ring expanding, and suddenly we can see that something is popped, and the shape of the posterior capsule tear confirms that the vitreous is already out. Now this was very surprising. Now let us try to dwell when it happened later on. How do we manage the situation now? The haptics are both in the bag and I have a PC tear, and the haptic is also likely in the same quadrant where the PC tear is. And there is definite evidence of vitreous. Now how do we go about? Couple of things which are running amok in my head is, after doing vitrectomy, should I keep the lens in the bag? Should I pull it out and place in the sulcus? This is the great debate which is happening inside me. And doing vitrectomy, should I just cater the vitreous which is prolapsed into the antechamber, or should I go behind the lens, behind the posterior caps, and do a more thorough antivitrectomy? So these questions are being bombarded in my head as I start my management. So diluted triamcinolone acetate is used to identify the prolapsed vitreous fibrils. So I'm going to use my irrigation cannula to just wash out all the triamcinolone acetate. And this is going to give me an idea of where the vitreous fibrils would be. And at this stage, I can see that some amount of triamcinolone has gone beyond the posterior capsule tear and is in the Burger space, which is to be expected. So I can see a couple of vitreous strands fluttering around. Time to perform the antivitrectomy. I'm using a cut rate of about 3500, a low flow rate and vacuum. And in a couple of seconds, the prolapsed vitreous which were there around the rhexis margin have been taken care of. Now the lens inside the bag is also acting like a tamponade, and there is no further prolapse of the vitreous. So at this stage I'm wondering, should I lift the lens and go behind the posterior capsule tear and then do vitrectomy, or should I just stop now? So that's the great debate which is going on in my head. So now at this stage I'm very much certain that there is no vitreous in front of the intraocular lens. I'm just trying to tap the lens a little bit with the cutter itself and to see whether it is stable or not. At this stage, the lens looks to be very stable. There is no vitreous in front of the lens or in the antechamber. The posterior capsule tear is same, it is not enlarged. So the debate is still going down in my head. What should I do? Should I go in and do more vitrectomy, or should I pull the lens out and place it in the sulcus? So before that, I thought, let me check where this haptic is. So with the irrigation in my left hand, I go in with the Y hook, retract the iris, and then try to visualize. Now I zoom in a little bit and I'm trying to delineate the posterior capsular tear. So I can see both the edges of the posterior capsular tear and the place where the haptic is. There is a small rim of posterior capsule still there around it. And so at this stage, I am more inclined to leave the lens as it is. So just double check again, go back and retract the iris and see that the haptic is sitting on the intact posterior capsular rim. So at this stage, it looks to be reasonably stable, and I felt that it is alright to just leave the lens there and then see how things turn out. Again, I go in with the cutter to confirm that there is no vitreous around the pupillary margin, and once I'm certain about it, I thought I'll just close. So before coming out, I want to hydrate the wound so that the chamber does not shallow, and the chamber looks to be stable, and that's it. So decide to close the eye. And these are the first day post-op pictures. The patient is having some amount of corneal edema. Pressure is around 24. She is being treated with anti-glaucoma medications along with antibiotics and steroids. And these are the 1 week post-op pictures. The cornea is cleared off. The lens is reasonably well centered. The pressures are all right. Now to the $1 million question. When did the PC tear happen? So let's rewind and see. So during the cortex aspiration, it looks alright. Nothing looks to be very suspicious. Next question. Did it occur during the intraocular lens implantation and dialing? So let's take a relook at it. So this is the lens is being implanted now. The distal haptic, as it lands, there is a small jerk which I notice, but there's no well-defined tear visible now. Maybe there is a small tear at this stage, but it was alright. The lens is dialed into the bag, and now I'm going to do cortex aspiration. The first few fibers of cortex are aspirated, but at this stage, when I'm trying to remove the cortex in this particular quadrant, an unusual membrane-like thing is accompanying the cannula. Now this, I believe, would be the posterior capsule tear. It is just seen momentarily, and again it falls back. Even at this stage, the posterior capsule tear is not directly visible. Only when we start to irrigate under the lens, that is when this small tear which was there initially hidden under the iris, it begins to enlarge. And if looked very carefully, we can see the semilunar shaped tear fleetingly appear at this moment, but at this stage there is no anterior rupture. The anterior rupture happens after a couple of seconds more, and you can see suddenly the posterior capsule tear enlarges and we have a second ring, that is the anterhyaloid. So this is my hypothesis explaining the events which were occurring before this large visible PC tear. There was a small invisible PC tear which got enlarged during aspiration, and finally the last nail in the coffin was when we had an irrigation which went in and the PC tear progressively increased, and finally the anterior rupture happened. Well, the reasons are very clear that as a routine I do the OVD removal from behind the lens, and in this case I was not suspecting any posterior capsular tear, so I went ahead to remove the OVD as I do in every other case. And this is when the PC tear actually enlarged, resulting in the anterior rupture and vitreous prolapse. And then I did a limited anterior vitrectomy only in the area above the optic of the lens. I really did not go behind the posterior capsular tear to do the vitrectomy, which I prefer to do usually. And in this case, the lens remained stable and the patient did well. So this was a lesson for me that sometimes some things are difficult to explain. So that was it. Thank you for watching and hope you found this helpful.